you have reviewed it. Did you get a chance? I see. I'm sorry. I mean, I tried putting it on Blackboard ahead of time, just so you get a chance. If not, just make sure you review it. Okay? All right. I understand that. No problem. So your textbook is called Radiology, which I have also mentioned before. So make sure that you review it from that book whenever you get a chance for your supplemental reading. All right. So whenever we do the thorax, before you start making assessment, the first thing is that make sure the positioning is correct, which means the patient should be straight on the table when you are taking a DD or BD. And when you are taking laterals, just make sure the ribs are as much superimposed as much possible before you start interpreting things, because you can misinterpret things because of the malpositioning. So that would be your number one. And the second thing is exposure technique. So, and we have discussed that, the KVPs, MAS, and the contrast. So make sure that is looking all right before you start interpreting the radiographs. Not first fix the technique before you go there. Okay? So these are the structures that we will be evaluating and going over. We'll see how much we can cover today, and then if not, we will in the next class. So we'll start with the thoracic wall. So as you know, thoracic wall is outside the lungs, which kind of covers the lungs, which includes ribs on the lateral side, spine on the sternum on the ventral side, and then what's the boundary on the caudal aspect of the thorax? It's the diaphragm, right? So diaphragm is basically the caudal boundary for thorax and cranial boundary for your abdomen. So make sure you include the diaphragm when you are taking thoracic radiographs, taking abdominal radiographs, because that's your landmark that you have reached to the back, all the way to the back of the thorax. That's you. So when we are looking at the thoracic wall, some of the common abnormalities that you will come across are the fractures. For example, fractures of the ribs and spine fractures are not very common, but you may encounter those. Sternum fractures or other conditions like maybe a foreign body abscess or congenital malformations. For example, there is a very common sternal malformation called as pectus excavatum, and I will show you the radiograph, how it looks like. Okay. So, can you identify the rib fractures on these? I think the one on the right here is a better one for looking at the fractures. Can you identify them? Where are those? Pardon me? I don't know what's the story behind it, because this is an image from a book, but it's pretty bad. Can you see the rib fractures on this image? Can you all see those? So there are multiple rib fractures. So you can see that one clearly, right? Almost all of these ribs are fractured right here, all the way to the back. Some of these are more prominent that you can see, and some of these are pretty much aligned together, but you can still see some misalignment, right? And then on the left side, it's mostly towards the caudal aspect of the thorax that these are fractured. Okay, so which view do you think would be more beneficial, lateral or a BD, when you're looking at the rib fractures? A BD, so we can actually look at individual ribs as compared to a lateral view where there will be more superimposition. Okay, question.
Is the fracture causing this image to look less radiolucent than it should be on the other side?
On the other side, you mean this image? You're comparing these two?
Are they the same?
No, these are different patients. Are you comparing the two sides of the same patient?
Yes, it's less radiolucent than it is on the other than the left side.
So what side is more radiolucent?
The left side.
The left side of the lungs, are you talking about, or the ribs? What is more radiolucent?
The lungs.
The lungs look more radiolucent? Do you all agree with that?
Yeah.
Yes, they do look more radiolucent as compared to the right side, specifically in this area.
Yes. Why?
Do you agree?
Why?
Why is that?
I'm asking.
I'm hearing hemothorax on this side. And what are you saying?
Edema and inflammation.
Edema, inflammation, contusions, hemothorax. And that's a possibility, yes. And if those things happen, it's going to look more radio opaque because now the alveoli is filled with maybe blood if there is hemorrhage, or maybe the alveoli are collapsed, so there is no air in the alveoli, so it's going to look more radio opaque. Okay, good job. I'm glad you were able to catch it. Awesome, and thank you for the answers. The same thing on this view. The fractures are not very clear on this one, but you can still see this radio opacity, which is like a fragment of the fracture, which is looking more vertical now. And then the opacities, do you see those? So it could be hemorrhage or it could be collapsed lung lobe. But this is more radio opaque. So again, for the same reasons. Good? So this is pectus excavatum that I was talking about. This is a congenital abnormality, which is commonly seen in dogs and cats. So in this case, there is deviation of the sternum into the thoracic cavity. Can you identify that? So see how far dorsal the sternum is going in. And do you treat this or not? Yeah, we usually don't because it's clinically the patient is usually normal, but if the patient is having any clinical signs, which will happen when the patient is pretty young, and then you may need to fix and do something about it. But if clinically there are no signs, you don't need to worry about it. But just make a note that this is a congenital anomaly. Okay? Yeah. Show it again, yeah. So this is the sternum, and you can see the different sternibri. So if you follow them along, it goes up in the thoracic cavity. Normally, it should be parallel here. That's where the sternum should be, right? And it's going in.
So are the ribs, I guess, after the subcondylar junction also kind of turning inward towards the sternum?
There will be, yeah. So everything is gonna look very crooked and abnormal, but as long as you can identify that this is congenital, and the patient is clinically normal, you don't have to worry about it. But just make sure you know it and don't get alarmed by it, okay? Because it looks very abnormal, okay? So this is a concept that you must know whenever you are assessing the lungs, and especially when you are looking for metastatic nodules. Metastasis is when the neoplasia has spread to the lungs, and then you will see some nodules, okay? So look at these two structures. They do look like nodules, right? But before you say there is metastasis in this patient, look at lateral view. Do you see those memes? So cranial abdominal meme, and they actually look like nodules on this PD. And see how symmetrical they are. If it was a true metastatic nodule, you should not be able to see this structure right here. And also, nodules are not usually symmetrical like this. They may be, but not usually. So whenever you are making interpretations, make sure you look at both the views, and you can correlate your finding on lateral as well as skin masses like lipomas or nodules that look like a nodule or a mass in the thorax.
By any chance, you had a weird case this summer. So by any chance you have maggots in the subcutaneous area, could you see them on radiographs?
Maggots. I'll try to find out an image and see if they are radio opaque or not. I'm not sure, but I will get back to you. Any other questions? So usually it depends upon how radio opaque I'm not sure how radio opaque the maggots are. I'll have to look into that. Question?
I have a response to that question.
Oh, yeah.
I seen a case like that this summer.
Mhm.
In terms of like radiopathy, it all depends on like the information or whatever for that tissue, because there was a cat that came in and had maggots around the rectum, and the maggots had, I guess they were there for so long that the tissue had became so inflamed. When you took the radiograph, you'll see like that soft information that kind of good.
Were you able to see the maggots or just the inflammation? Could you identify maggots on a radiograph?
No, at least from, it was just like you would see, like, I want to say radiotape nodules, I guess.
Yes, you can definitely identify if there is inflammation, like granuloma. If that has formed because of the maggots, granulomas, you can definitely identify. And thank you for your response. Maggots, they should not have bones or skeleton. Like, you should not be able to see radiopaque maggots, is my best answer from my knowledge. But if there is inflammation, like you said, or subcutaneous emphysema or granulomas, because of that, those changes you can definitely identify. Thank you. Okay. So, different masses in the thorax. You must understand this concept. So whenever you see a mass in the thorax, you have to come up with an answer. Is it coming from the lungs, or is it outside the lungs from the pleura or from the thoracic wall? So how do we differentiate those? I mean, it's not a rule which applies, but it kind of gives you, it's a guideline. So look for these things. Usually when there are extrapleural masses originating from the thoracic wall, they have a broad base. So this is the one from thoracic wall, and then this is the one inside the lungs, so parenchyma. So see how different they are, first of all. This one has more smooth margins as compared to this one. Look at the margins of this mass here. They're very fuzzy, not very smooth. Some of these are pointies, like if you zoom on it, I cannot zoom on it here, but if you would zoom on it on the digital image, you can see the architecture of this. So it doesn't have a smooth margin like a extrapleural mass. Okay. The second thing that some people look for is the angle between the margin of the mass and the thoracic wall. Draw an angle like this. If it is extrapleural, it should be more than 90. And if it is intrathoracic, for example, this one, if you draw an angle from here and here, this one looks pretty much like 90 to me. Okay? So if it is obtuse angle, it's usually extrapleural. If it is acute or 90 degrees, usually intrapulmonary. Okay. And this is just a description of what I just told you. Extrapleural sign extrapleural sign is a term we use for extrapleural masses. So what are those signs? Invagination of the pleura into the thoracic cavity with a broad base appearance. And I just told you that, like this appearance, like it starts here and then goes up like that. And rather than terminating right there, it goes like that. So this is a broad base as compared to this one, which just comes in and stops. Okay? Smoothness, we have talked about it. Can appear as a lung lesion, so you have to try to differentiate whether this is lung lesion or not, but it can definitely look like as if it's coming from the lungs, and it's not. Okay? So look for pleural effusion as well, which I'm gonna cover next. Question?
Can you draw the angles on these two?
This one, these two? Okay, so for example, for this one, it's gonna come up like that, but the opposite side. So you can draw the vertical line here, and then the horizontal I would go here with this thing. So tangentially, you are just going through the mass, okay, through the margins. And then for this one, I would draw here, and then it pretty much comes out straight from here. Do you all agree? If you don't agree, then I would suggest that you draw the lines yourself. And then if you're having any trouble, then you can see me in my office. And then we can go together. Okay? Alright, so this is just the same thing again, repetition. But one more thing I'm gonna add, that with the extrapleural signs, if the masses are originating outside the pleura, another common finding is you may see some swelling in the soft tissue opacity because it's not inside the thorax, it's pretty much outside the thorax to begin with. So there is some soft tissue swelling in this case, and then the same mass is actually protruding inside the thorax. Okay, so this is giving you a clue, the soft tissue swelling on the side of the thorax, that this is extrapleural. The other sign which is giving you a clue is rib destruction or lysis. Can you identify that? So compare it with the other ribs. This one and then here, you can identify the margins of both of these. But if you look onto this one, you just lose those margins. So there is lysis of the rib, which is another extrapleural sign. Okay? So just look for those changes and they can guide you whether the mass is inside the thorax or outside. Good? Pleural space is the space between the visceral and parietal pleura, right? And if there is fluid accumulation in the pleural space, we call it pleural effusion. And if there is air or gas in the pleural space, we call it pneumothorax. Okay? So let's go over those. Have you guys covered pleural effusion in medicine? Not yet. Next section. Okay, now you have some basic information and then you can tie it in with the medicine lecture. So it can be classified based upon what type of effusion is there. So for example, if there is a rupture of the thoracic duct, you get chylothorax. Okay? If there is hemorrhage in the pleural space, we call it hemothorax. If there is pus or infection of the pleura, like pleuritis, and there is pus accumulation, we call it pyrothorax or angina. Hypoproteinemia is, for example, when there is hypoalbuminemia, and it's going to give effusion. Why is there effusion in hypoproteinemia? Yeah. Yeah, you got it. So, decreased osmotic pressure in the blood vessels is leading to pleural effusion. Now, because it is a generalized condition, you will also get peritoneal effusion commonly. Okay, it's not going to just restrict to the pleura. Heart failure, specifically in cats, you will see pleural effusion. It's more common in cats. If there is neoplasia, specifically extrapleural, for example, from the rib tumors or lymphosarcoma, which is commonly seen in the mediastinum, it is associated with pleural effusion as well. Diaphragmatic hernia is another. And idiopathic, we don't know why, but it happens. And in cats, the common conditions are hypertrophic cardiomyopathy and chylothorax. So you should know these differentials whenever you see pleural effusion, like what diseases to think about when you see that sign. Okay? Now, radiographically, you cannot differentiate chylothorax versus hemothorax versus pyrothorax. They are all gonna look the same. Do you know why? Yep, and fluid opacity is gonna look the same no matter what's causing it. Good job. All right, so what are the signs of pleural effusion radiographically? Leafing of lung lobes. The leafing is also called as retraction of lung lobes. Same thing. Fluid radiopacity between the retracted lung lobes and thoracic wall. I'm going to go over these. Pleural fissures is accumulation of fluid in the pleural fissures. Okay. Rounding of costophrenic angles, specifically on the VD view. An obscured cardiac silhouette and diaphragm, because again there is fluid accumulation. So let's go over these. So this is leafing of the lung lobes. Can you identify that by yourself? Okay. Okay, let's. Yeah, so here, can you see the skeleton?
No.
Okay, so you're all right there. Well, it's dorsal and ventral. So if you're looking up here, yeah, it does look like a pattern of the leaf, right?
Okay.
Don't get too much involved with the leaf. think about the tissue, the lungs and the fluid. Where is the lung and where is the fluid? Okay. Leafing is just to help you get started, like look for the leafing. But think about the lungs here. So they are collapsed. Normally they should be extending all the way out to the thoracic wall. So for example, here, the lung, you should not be able to see these margins. It should be extending all the way out, but it's not because there is fluid accumulation here. Okay?
So you can call that collapse lung.
You can call, so we will call this collapsed lung, you can call that, because of pleural effusion. Because now the alveoli cannot expand because there is fluid outside. Okay? Now, there's a difference between pleural fissures and leaping of the lung lobes. So when there is a small amount of pleural effusion, the first sign you will see is pleural fissures. But if the pleural effusion is huge amounts of fluid, then leaping of lung lobes is more commonly seen. So in the beginning, you will get pleural fissures. Okay? So this is just a normal anatomy view of the lungs. And you can see these pleural fissures, how they look on different views. So A, B, C, and D, and then it's giving you what see the patient is in. And then this is how the fissures will look like on the radiographs, where to look for them. So wherever there are lung lobes, between those lung lobes are the pleura, which is invaginating in, and that's where the fluid is going to accumulate, in between those lung lobes. Okay? Any questions? All right. And this is how they look like on the radiographs. So with these arrows, can you see the radio opaque lines? All of those are pleural fissures. And I'm not seeing any leaping of the lung lobes here or collapse of the lung lobes. Because the pleural effusion is so small amount of fluid in this case that I'm only seeing some fissures. That's why. So you don't always see all the signs. If you still see the fissures, not the leaping, it's still pleural effusion. Okay? The differentials will be still the same. Alright? In this case, I can see the fissures with the white arrows here. And then if you look at the lung lobes, the cranial lung lobes on both sides, you see how the margin of the lung is getting away from the thoracic wall on both sides? And that's not how it should be. It should be extending all the way out to the thoracic wall. So this margin here, it should go all the way out here, up to here, and it's not. So this is called as leaping of lung lobe or retraction of the lung lobe. Separated by a soft tissue opacity between the collapsed lung lobe and the thoracic wall. And this is soft tissue opacity because there is fluid in the pleura. Should I repeat this or are we good? Question?
So what we're seeing right there in the black arrow, it's actual tissue, right? It's not the fluids, right? But it looks more radiopaque.
What, I'm sorry, what is the tissue? The radio opacity or the radiolucency?
Radiopaque.
Is the tissue,
Or-
it's fluid.
Okay.
The lung tissue is radiolucent here. All of this is the tissue. And this is all fluid, the radio opacity. And then outside here is the thoracic wall. So, did I make it clear or?
Yeah, I think I just got confused with the previous radiograph, the one that had lateral side. Because you had,
Let's go back.
so that one,
Mhm.
the cranial dorsal part, so there's the leafing in that part too.
Mhm.
So I guess was how is the fluid out there? That's the lateral one.
So how is the fluid on the dorsal side? Is that? Because there is so much fluid, like there is so much fluid on the ventrum here, and now it's also going up. If there was only small amount of fluid, you may not see anything on the dorsal. You may see it only on the ventral side. It depends upon how much fluid is in there, that how it's gonna look like on the radiograph. So it depends upon how much fluid is in there. If it's a lot of fluid, then you will see it on both dorsal and ventral side. If it's a small amount, you will see only on the ventral.
So you have lung tissue, fluid, and pleural.
You have lung tissue, this is all lung tissue which is radiolucent, and the radio opacity outside the lung tissue is the fluid. Clear?
Thank you.
You're welcome. So between the lateral and the VD view is gonna give you more accurate diagnosis of pleural effusion if it is small amount of fluid. Because you can identify pleural fissures more clearly on a VD than a lateral. Okay, but make sure you take both views and look for those changes in both the views. Clear? There's one more sign that you may look for. So compare the mediastinum here versus on this one. So the soft tissue opacity, cranial to the heart, on the midline, all of this is mediastinum, cranial mediastinum. Okay? So if you compare mediastinum here versus here, you can see there is widening of the cranial mediastinum. Can you appreciate that? And this is another sign of pleural effusion on a VD. You may not see that on a lateral, but you can see that on a VD or a DV because now the fluid is pooling up on the dependent part. Okay? Because the fluid is going to move how you position the patient. So that's why the appearance on the radiographs is going to change with the change of the position. Okay? Any other questions? I'm going slow today because this is very important concept and you will be seeing these patients throughout your career. So you need to know this. So this is another pleural fissure and you can see the radio opaque line on the caudal border of the heart. Okay? But this is going to be more clear on the VD because somebody can miss out on this pleural fissure. So make sure you take both the views and you look for these fissures when you are suspicious of pleural effusion. Another sign is rounding of the costophrenic angles. So costophrenic, as the name suggests, the angle between the ribs and the diaphragm. So this on the left is normal. So you see how like pointed angle it is between the diaphragm and the thoracic wall. See how, what do you call it, like a triangular angle? It makes like a pointy edge, right? And compare it to the other ones. So look at the angle here, and then look at the angle here, and then maybe here. So it's not as pointed as it should be normally. And that's because of accumulation of fluid between the lungs and the thoracic wall, which is pleura. Can you identify the pleural effusion easily on this one maybe? Yeah. So whenever there is a radio opacity between the lung lobes and the thoracic wall, it's going to be pleural effusion. If it's air instead, it's going to be pneumothorax, air in the pleura. Okay? So like I said, you cannot differentiate the type of fluid radiographically. So your next step will be perform a thoracocentesis and do the fluid analysis. So fluid analysis will be covered in clinical pathology or medicine part, like what to do about fluid, okay? But radiographically, you should be able to identify. Any questions so far? All right, so let's move on to pneumothorax, which is air in the pleural space. And commonly, it is associated with trauma, and we call it open pneumothorax. But there is also another which is called tension pneumothorax. We'll cover tension pneumothorax later because I have this information on a later slide. So radiographic findings for pneumothorax. Again, there will be retraction of lung lobes. There is radiolucency between the lung lobes and thoracic wall. Radiolucency because now it is air. Okay? And there is elevation of the heart from the sternum by the air. So we'll go over these one by one. Now again, it depends upon the amount of air. If it is small amount of air, because air is lighter, it's going to go up towards the dorsum. So you will see small amounts of pneumothorax. On the lateral view, it's gonna be on the dorsal region up here. So you see that radiolucency, and then these are the margins of the lung lobes, right here. So the lung lobes, normally they should be extending all the way out to the thoracic wall. But now they are retracted, and there is radiolucency between the thoracic wall and the lung lobes. Okay, question?
Is there a reason why the lung lobes, I may be missing everything, but is there a reason why there's radio opaque capacity in around the lung lobe?
Radio opacity around the lung lobes.
So you see where the arrows are,
Mm-hmm.
that's radio, right?
This
And then
area,
versus the lungs, which I'm used to seeing more radiolucent versus that radio opaque.
so your question is why the lungs are looking more radio opaque? Is that what your question is? Okay. Anybody who wants to answer that? It's collapsed. Okay. I heard one answer that the lung tissue is collapsed because of the pneumothorax. That's why it is more radio opaque. Any other answer? Do you agree with that answer? That's correct. You have an answer?
Just building on what you said,
Uh-huh.
the radiolucency there is because that's with air, not with the tissue, whereas the other one is air tissue.
So you're talking about this radiolucency here?
That's because it's a pneumothorax. so
That's
it's just air.
pneumothorax. Mhm.
And then the lung itself is lung plus air. So it
Yes.
could collapse.
So I cannot tell how much air is in the lungs right now based upon the radiograph, but I can definitely see that the lung, I can see the margins of the lung lobes because now some of the tissue in that lung lobe is collapsed and now it's looking more radio opaque, but there could be some air in that lung lobe. Maybe it's not completely collapsed. So there is some radio opacity, some radiolucency, depending upon how collapsed it is. Okay? So now when there is a large amount of air, it's gonna look like this. So you will see the elevation of the apex of the heart from the sternum by a radiolucency. Normally the apex of the heart, it should be lying here on the sternum. Okay? But now it is elevated off the sternum or dorsal to the sternum because of the radiolucency, and that's why it's pneumothorax. But make sure you confirm this on the VD as well, because sometimes you may get this appearance in other conditions as well, such as pneumomediastinum. Can also give you elevation of the heart dorsal to the sternum. Or if there is hypovolemia, which means you will get a smaller heart. If the heart is smaller because of hypovolemia, it's gonna look smaller and it's gonna be dorsal to the sternum. So you have to think about different conditions that can cause the same radiographic appearance and then make sure you can correlate those findings on the VD. So I'll tell you how to differentiate pneumothorax from a pneumomediastinum. We will cover that later on. And then hypovolemia, you can go with the physical examination. You can look at the blood vessels. We'll talk about the blood vessels later on. But there are ways how you can differentiate those. Okay? Do you have a question?
Yeah. So, in terms of this lateral view, if we're having pneumothorax, why is it the air, like on the previous slide, going dorsally? Why is it going ventrally? Would it have an easier time pushing the lungs down rather than the heart up?
Uh-huh. There is some on the dorsum as well. So if you see right here,
Yeah, I see that, but I don't understand why it's more ventral.
why
Like,
it's more ventral. I don't have a great explanation on that, why it is not more dorsal and why it is more ventral on this view. I'll get back to you. I'm not sure, because you're right, like if it's air, it should go more dorsal than ventral. But you know, it's not like it appears it's ventral, it's actually in the mediastinum, it's in the center. It's not dorsal or ventral. This is the best explanation I can come up with, because I don't have the VD view. Let's see if we have a VD view. But it's not helping with the mediastinum. But okay, let's think about the pneumothorax. So it's the air is in the pleura, and the pleura is connected with the mediastinum. So when the pneumothorax happens, the air leaks through those pleural pores and enters into the mediastinum as well. And heart is sitting in the mediastinum. So all that air in the mediastinum is now just pushing the heart to the side. Can you think about it in the 3D? So think about a VD of a dog. The air is escaping from the pleura, going into the mediastinum, and now shifting the heart. Okay? When you take a lateral radiograph, all you are seeing is shifting of the heart. So this air that you are seeing ventral to the heart is actually in the mediastinum. And some of it is in the pleura as well. Does that help?
Yeah.
So I'm not sure about the physics or why it's like that, but it's just how it appears radiographically. But I can go and see if I can come up with a further more explanation. Okay? Good? And this is on the VD. So you can identify the lung lobe margins on all the sides. Can you see that? And the lungs are looking radio opaque, and now we know why. Because they are collapsed. They are not completely expanded with air. And there's radiolucency outside the lung lobes, which is any questions on this? Alright, sometimes we get confused between a skin fold versus a pneumothorax. Now look on the both sides. One of these is a skin fold and the other one is a true pneumothorax. Okay? So there are two ways how you can go with that, how to differentiate between the two. If it is a skin fold, it's going to continue to the back of the thorax, like corner to the thorax. So if I follow this, I can still continue this, and then I don't have the further back, but it should stop in the lungs if it was a true pneumothorax. Okay? The other thing is look for the blood vessels. I can identify the blood vessels in this radiolucency, whereas there are no blood vessels on this side. So depending upon presence of blood vessels, that should be present only in the lung tissue. So if you can identify vessels or lung markings, then that's the normal lung tissue and you are seeing the skin fold. But if you lose the vessels or lung markings, then that is a true pneumothorax. Okay? So this is a true pneumothorax on the right side because you cannot identify the vessels in this radiolucency. Whereas on this side, can you identify the vessels here? They are very subtle, so you have to maybe look on your computer screen. Maybe that will help. But when you come to radiology, we have those digital systems and you can zoom on it, you can adjust the contrast, so it makes it better, and then you can identify it that way. Okay? All right, tension pneumothorax. How many slides do we have left? I think it's the last. Okay, we'll stop after that. It occurs when it's more physiologic, or when there is no history of trauma, then and you still see the pneumothorax, it could be tension pneumothorax. Okay? And it happens when the air is escaping into the pleural space, but it cannot come back out. So it's all going in, not coming back out, and that's how the tension pneumothorax develops. Again, the radiographic signs will be the same, but it's going to be more unilateral than it's going to be bilateral. Okay? Open pneumothorax, mostly you will see bilateral. So there are a couple of signs you can look for. Again, you can identify the collapsed lung lobes. and there is air outside the lung lobes, in between the lungs and the thoracic wall. This is all pneumothorax. And on the opposite side, there is no pneumothorax, right? So that gives you a clue that it could be a tension pneumothorax. Okay? Again, on this view, on the lateral view, you can see the collapsed lung lobe. And also, if you see here, the diaphragm is more caudally displaced because of the air inside between the lung lobes and the diaphragm as well. Okay? So it's gonna look like the same as the open pneumothorax, but it's gonna be more commonly unilateral. That's the only difference. Okay? Do you have any questions on any of this? So in the next lecture, we will continue with the diaphragm and the pneumomediastinum. And you are welcome to review the lecture so that you are ahead of game. Okay? All right. You have good wishes to you on your surgery today, or anesthesia, whatever procedures you are doing. Good luck.
I'm gonna help Christina plan her outfits while we're in the going round.
I still don't know what's going on, but it's okay. I ask her later.
I'll be tired.
What are we doing? I think we're going to test after.
I don't know what's going to be.
Yeah, I don't know.
Any details, so just